TopMedTalk.
Nick Aronson here. Welcome to TopMedTalk. Time now to listen to the POCAPALOOZA. What's that? Well, POC, Perioperative Care. And then a palooza is an extravagant event or celebration of some kind. And that's what this was. We celebrated perioperative care and we took the message around the world in the wake of EBPOM Live from London 2020. Don't forget, of course, EBPOM Chicago being planned for now. I highly suggest you get onto ebpom.org to find out about the incredible ticket offer we have going right now. ebpom.org is the place to go. In the meantime, let's have a listen to this. The POCAPALOOZA.
We are still going strong with the POCAPALOOZA. Congratulations to the entire EBPOM team for a phenomenal meeting. I have to tell you, Monty, we were getting people from all over the world. This is not first world. This is not just in the UK, United States, or Australia. It's Africa, the Middle East, Asia, kind of all over. So thanks to everyone.
It's a global POCAPALOOZA. But also in the studio is Mike and Denny.
Hey guys.
Hi, we're still here.
You're here. You're like, we're still here on stage. It's awesome. Thanks, guys, for sticking around. And it's my pleasure to bring in our guests from EBPOM USA, from Chicago, Saul Aronson, friend of the EBPOM family, and Jeanna Blitz. Saul, for those that may not be familiar with you or your work, tell us just a little bit more about yourself and what you do there at Duke.
Father of two, devoted husband, pretty good golfer, so that's relative.
Oh, he's a comedian.
I don't know if
Yeah, it's great. It's very funny, Saul.
We, going on 6 years, have been running what we term the PASS clinic. We were able to describe that sort of recipe for standing up that clinic a couple months ago. It was published in the Anesthesia and Analgesia journal. So it's a new approach to really changing the paradigm from just evaluating a patient and sort of passing that information forward to the receiving team to help them better understand what kind of risk profile a patient might bring to the operating room. Rather, we take a much more proactive, progressive approach to identify those chronic comorbid conditions and try to bend that curve. We try to modify that which is modifiable. And 6 years into it, we've been able to accumulate some pretty, excuse my French, badass data. And we talked about that a little bit, earlier in this session 2 days ago, and we continue to accumulate that. So pretty bullish on it. We will continue to accumulate our data and continue to wash and clean and beat up that data to make sure that our messaging is credible. But I think so far it's a pretty exciting story. We were lucky enough to recruit Jeanna from New York to come join us here in Durham to run our PASS clinic, our perioperative anesthesia and surgical screening clinic, the sort of paradigm that I just described. And Jeanna has taken us to the stratosphere and has been just the clouds opened and she fell through. And so much of what we've been able to do is attributable to Jeanna.
Congratulations, Jeanna. Tell us a little bit more about yourself.
I'm an anesthesiologist. I trained at Mass General in Boston, and then I spent the first, it was about 12 or 13 years of my career at NYU in New York City. I've been working in the perioperative medicine space since about 2011. So I have, for many years, tracked Dr. Aronson and some of the other giants in our field in the United States here, like Dr. Bobby Schweitzer, who I know makes appearances at EBPOM. And I've been so thankful to have their mentorship along the way, who have encouraged me and supported me in my interests. I still divide my time between the OR and my pre-op clinic. I'm on call tonight. But between now and then, I'm excited to be here and talk about perioperative medicine.
Featured speaker at EBPOM Chicago in September, by the way.
That's right.
Yeah. Jeanna Blitz is going to be joining us for sure, Jeanna. So we're excited to have you participate. Saul, do you want to tell us a little bit more about EBPOM Chicago meeting?
We, like everybody else in this world, didn't anticipate getting punched in the gut and rapidly had to pivot to making sure the show goes on. Just like we just witnessed in London, that happened phenomenally well to be able to pivot at such short notice to create a virtual platform. It is our anticipation that Chicago will be virtual as well. We really do not expect that there will be any on-site participants. Nobody has a crystal ball. We can't predict, but we're certainly planning for Chicago to be a similar format. So we're working diligently behind the scenes, even now, in parallel processing with the London show to stand up the Chicago show. So it's going to be equally dynamic and exciting and informative. And I really hope this discussion continues. It's not just because of the opportunity for us to stay connected. Even COVID won't let us stay apart from one another. Perioperative care is a very dynamic, very rapidly evolving, very important, if you will, discussion. And this is just our way in the EBPOM sort of vernacular to keep that discussion going and to keep it meaningful. And so Chicago, September is our next attempt to do that.
So, Sol, we were hoping that by Chicago we would be having some form of hybrid event. And by that I mean that we were hoping that we would be able to gather as a limited size group here in the United Kingdom. We doubt we'd be coming to Chicago, but that we would form a sort of spoke to your hub, and that hopefully that people would be able to gather in your hub, and that we would get some of our traditional groupings around the world to have gatherings too. So we've held UK meetings, EBPOM meetings in Newcastle before, in Exeter in the West Country before. We obviously have our Ireland meeting, our Hong Kong meeting, we have our friends in Cape Town. So we're hoping maybe groups of 10, 20, 30, maybe up to 50 people will gather, and we can move on to it being a hybrid of actual socializing together and global sharing. Really, really hope that that's the way it will go next.
The virus has its own opinion about that, and we have to, defer to the will of the virus. But eventually we'll get back to what we presume to be normal. And I think that is going to be sort of way of the future. And we're looking forward to that. If not by September of 2020, our next EBPOM meeting will be Las Vegas in January of 2021. And then, of course, the cycle continues with Dingle in London, and we keep on that carousel. Eventually, we'll get to that place where we'll have pockets of gathering like-minded, interested people in their zip codes or counties of note, and we'll sort of break bread virtually with them.
I think one of the things to look forward to for the EBPOM Chicago meeting is the fact that we're going to try and mix it up a little bit. Technically, during our Chicago and USA meetings, we try and do a lot of more workshops. We really didn't attempt that for this initial EBPOM meeting, but we have some really, really cool workshops around CPET and POET. So, giving that back to Mike and Denny about how we can possibly make something like that work. I know we're going to talk about anemia. We're going to talk about enhanced recovery after surgery. Lots of great workshops. ERAS cardiac.
I was listening to the meeting through one earphone. Literally, we were recording somebody doing a POCUS workshop, showing how to do a handheld ultrasound in the back of the room. And so we're going to have a POCUS workshop in Chicago as well.
One of the things that we wanted to do during the POCAPALOOZA is find out what's happening in the different areas of the world when it comes to perioperative medicine. And Jeanna, I'd like to go to you. I know from your perspective, especially coming recently from New York and working with others in the perioperative care setting within the U.S., from your perspective, how are you seeing things move in the United States?
Well, I would say from my perspective here in the U.S., we're focused on organizing ourselves around frailty and expanding that concept of frailty to include other vulnerabilities within the perioperative period that leave a patient more vulnerable to an adverse event. So whether those are social determinants of health, whether that's, again, true psychological preparation or other issues, health literacy, et cetera, that we're expanding the concept of frailty and we're organizing ourselves around how to best care for the patients who are most vulnerable. I'm certain that our colleagues around the world are ahead of us, but that's where our focus is these days, and it aligns quite nicely with what's happening in our neck of the woods in our country as well. So I think we have the right momentum right now to capitalize on the attention that's being focused to make some significant strides. So my particular focus is on health literacy, which I know sometimes can be controversial about whether that actually further stigmatizes a patient to assess their level of health literacy or not. I know that Angela Bader is also quite a proponent of that. And the reason and the focus of my interest in that has to do with, I believe at the core center of everything we do, there must be true shared decision-making that occurs. And setting off that conversation and preparing that patient to engage in their care is the catalyst from which everything else builds and sustains. And without engaging that patient up front and understanding where they're starting from and meeting them there, my personal opinion is it's difficult to succeed. I would say that we're focused on shared decision-making and goals of care conversations and techniques to partner with the patient in their care and then engage them further and bring them up rehabilitate their level of preparation psychologically, mentally, socially, to be able to sustain the journey of surgery and recovery.
And Desiree, if I can interject, I'm going to throw another hanging curveball over to Jeanna, just to sort of carry forward that thought. Jeanna, have introduced, if you will, a scripted protocol that many of our advanced care providers that work with you in the past clinic have already begun to rehearse and disseminate in their routine intake.
I have a group of residents that come through my rotation who are interested in perioperative medicine, and I truly believe that is our future, to feed the pipeline of interest in perioperative medicine and to role model that for them. What we learned along the way was that they were having a great time engaging in the clinic, but they didn't feel comfortable with how to approach a patient about some of these sensitive topics because it wasn't necessarily something they had had much practice with in the recent past. And so what we learned was that the conversations were that much more effective and real when we gave them a sort of template to work off of with prompts about how to approach a patient about sensitive topics, about a recent cancer diagnosis, or about what their goals might be when they have a life-limiting illness, and how they had conceived of themselves continuing to manage symptoms that may extend beyond the surgery despite the fact that they need the surgery, and thinking about their goals for recovery and that process of recovery and how we can optimize it for them. So we've created a sort of standardized template, which number one is great because it serves as a prompt. It gives ideas about how to broach this topic, and it also serves as a documented way for us to communicate back to, let's say, our surgical colleagues or our geriatrician colleagues to say, can we talk about this patient, and sort of send them a copy of what we've documented the patient has told us and where there are potentially some gaps or lack of insight.
I'm sure very, very useful to residents and other people who are not as familiar in the setting. I believe that there probably are providers who have been in this business for a while that still have a difficult time with that conversation. So how, are you utilizing it for other people who have been doing this for a little while as well?
So we started with the residents, and as some of the residents described my pre-op clinic, they call it a QI hive, because we're always iterating around things. And so there's always a product that continues to evolve. And so our first group was to get the residents comfortable. And we thought if we can get them ready to go, then we can expand it to our other nurse practitioners and physician assistants and other advanced practice providers in the clinic. Ultimately, though, the goal and discussions we've been having with our multidisciplinary care team is to roll this out, in fact, to other disciplines as well, including our surgeons, our hospitalists, our geriatricians, so that we are doing our best to standardize the way we approach shared decision-making for our patients that do.
Yeah, that's great. I kind of wanted to bring Mike and Denny in. Have time, don't we? You know, we've been talking a lot about shared decision-making, the entire meeting. So, Denny or Mike, you guys decide who wants to talk first. Can you share some of the insights that we've gained along these same lines?
Yeah, very much so. It's a sort of a worldwide movement really now, and it's about putting the patient at the centre of everything we do. And in perioperative medicine, it's a really key point in the pathway is the point where we might actually make the decision to proceed or otherwise with surgery. One of the things that we've learned is that some of the time we've been doing things in a slightly back-to-front way, as in we say you've got a surgical disease, you need an operation, now we'll see if you're fit for it. We're all thinking about focusing that decision earlier, but also all of us learning it across all disciplines that it's a conversation that can't, particularly for the high-risk patients where it is difficult to balance potential harms with potential benefits, that it's not a decision that's going to occur in one clinic visit in 10 minutes. It takes time. It takes a patient having, particularly, as we start to educate our patients as well as our clinical colleagues, I think at the moment they don't necessarily always turn up with the expectation that we're going to involve them more about what they want. And actually, they need some time to consider sometimes the information we've given them about possible outcomes of surgery, particularly when they've just been thinking that the surgery has been offered as this is the golden cure, then all the problems will go away. My experience locally in our trust and across the UK, we've been starting with some standardised workshops. It sounds very much along the lines we've been talking about. We've named them the Magic Workshops. Rami, one of my colleagues at Guy's and Thomas's, who's the NHS England lead for this, has very much focused on starting small. At the beginning, the people that turn up, they tell you they all do it anyway. By the end of the day at their magic, they discover that they haven't actually quite been doing what shared decision-making is. I think we all should reflect on the fact that 90% of doctors seem to think they do it and about 30% of patients think they receive it. Really like the idea of standardised training of first clinicians. We now have UHS, the first part of our trying to embed it across the trust has been actually a patient education journey, which is we call the Ask 3 questions. 3 very simple questions. What are my options? What are the risks and benefits to me? And where might I get more information? I just think we should think about those things at the same time. We need to educate our colleagues, but also start to educate our patients that they should remember to ask us. And if we arm them with the information that they're expecting that information, then that will help with our more reticent colleagues, shall we say, who think they do it anyway.
So easy and appropriate to immediately link that to the decision that should be shared with the elderly, morbid, frail patient to determine whether or not surgery is the right course of action or not. That it's much broader than that. That it's a shared decision process even for the patient who, of course, needs surgery. So where there's no doubt about whether or not surgery is the right thing to offer, there still needs to be a shared decision process. And what I mean by that, Denny, you just touched on this, is that so often people think that if they have a problem and surgery is the recommended solution for the problem, there's a presumption that therefore when I have surgery, the problem will go away and we're ready to move on. And what is lost in that translation, and this is a paradigm that is pervasive, is that people have to be ready for surgery. It's not that simple to just have surgery and get better, that you have to prepare for surgery. It's kind of like Rocky Balboa preparing for the fight against Apollo Creed. You got to train to get in the ring. And when you train to get in the ring, you'll have a better outcome than if you don't train to get in the ring. So the shared decision making is not just for the decision of whether to have or not have surgery, but it's also to have the patient be invested in their own well-being and to know that they need to do stuff in order to get ready. They may have to go to the infusion clinic to get iron. They may need to take hyperalimentation for a couple of weeks to get their nutrition set up. So they have to buy into it, and that's equally important in a shared decision-making in fuel context.
Okay, and go ahead, Denny.
So I would say I very much agree with you there, Sol. And I think it's increasingly preparing patients before they even come to either a perioperative medicine, prehab, high risk, whatever sort of clinic, or even just the normal clinics. It's about this pyramid of care as well. At the bottom there's the universal bit that everybody needs. We all need to know, as you said, you need to prepare for surgery, you need to engage, you need to think about your activity, your diet, your alcohol behavior, your smoking. Everyone needs to know about that, and that's for the rest of their life, not just their operation. And then as you go up the pyramid to the small group at the top where everything about their surgery might be complex, it risks and benefits, the fact that they may need interventions for frailty, anemia, poor fitness, nutrition. If they want to go down that path, they need to invest a lot. But I think early, at the point of when they're first referred, giving them information. So we now are going to be sending out with any clinic appointment at our entire trust, not just for surgery, for everything. Patient gets a card that says, ask 3 questions. You should ask, when you come to clinic, you need to come armed with this. What's my condition? What's the risks and benefits of any treatment you're going to tell me? And where can I get more information? And, what do I need to do? At the bottom, what's my side of the contract as well, I think is important from the patient point of view.
I think that there are a couple of factors that are probably playing in our favour here. The wind is blowing in our direction. One, I think, is that we have to commend our surgical colleagues for engaging with this and actually engaging very constructively with it. And I think part of that relates to the increasing reliability and prevalence of the outcome data. So they're much more understanding of when it doesn't go wrong. You need to look at the data to see that, and often that hasn't been available. And I think COVID will have helped us a lot. I think the engagement of the general population with the notion of health risk factors will hopefully change us. The global Choosing Wisely campaign, the brand formulation is very neat. So the benefits, risks, alternatives and do nothing approach, which surgeons seem to like, as a really neat formulation.
Thank you for that, Mike. Jeanna, I'd like to pivot back to you because everything that they were saying, I saw you like preaching the choir, right? We all believe in this.
In the conversation with the giants in the field, as I said, I'm having a great time.
Good. Well, one of the things I wanted to ask you is that, Denny and Mike and all you guys, all the conversation that came out of CPOC today and all over the UK have a real handle on it. Here in the US, where do you see a lot of institutions moving? Because for me personally, you see little pockets here and there, and you guys have done amazing things at Duke. But, where are we heading? What do you see as the future of that here?
One thing that we've been talking about and discussing and trying to make the decisions around have to do with how do we utilize and leverage telehealth capabilities to reach as many patients as possible, while at the same time not suggesting that everything can occur virtually. And so starting to wrap our minds around how do we make this technology work for us in terms of reaching patients who are further away, maybe having more frequent check-ins, what can be done virtually, as well as what do we really need to do face-to-face because the value remains. And so I would say that many of us in the U.S. are having these conversations, both online and off, about, hey, how are you using telehealth? What are your criteria for what you can do and what you don't? And what we've learned is that many of our patients actually quite enjoy telehealth and are even more apt to get on calls with our smoking cessation specialists and our cognitive behavioral therapists by phone, because they're sitting at home and they're feeling more comfortable and they're relaxed. And so there is absolutely opportunity to capitalize on this modality in a way that makes impact for our patients. And then I would caution that there are other times in which a telehealth visit is not enough.
The broader subject of training and education as well. I think from what we've learned from doing this conference is a partner with all of that is our increasing familiarity with using the technology, communicating this way. And therefore, I think we're all going to be much more comfortable now with telehealth. We just have to keep forging and travelling down that path rather than going back to the norm. Can I just touch on education for a moment and ask Sol to reflect on the first year of the so-called Morpheus Fellowship? And then, I don't know if Desiree's told you her new news, Sol, but reflect on that for a moment, and then she can tell you her news.
Well, I'll make my answer brief so we can jump right into the new news. We is a collaborative between UCL and University of Southampton and Duke. We, years ago, sort of sat around, the big oak table with a few glasses of beer and other accoutrements and came up with this crazy idea that we should forge together and bridge our collective sort of spirit and innovative efforts to do something meaningful in the world of perioperative medicine. And one of the byproducts of those discussions was to create, so far as I know, the first virtual perioperative medicine fellowship, which utilized the technologies of on-site and online in a combined way to provide this sort of curriculum to those who would otherwise not be able to have a traditional boots on the ground fellowship. And we just graduated our first class of 5 fellows. We had a relationship with North Star Anesthesia to offer this product to anyone, and they were progressive and early and edgy to accept it, and now are the recipients of having 5 graduates from that program, which is very, very rewarding to see and certainly exciting to report. We're on our way to year 2, equal vigor. Desiree, please share your news.
Well, as of yesterday, I am now the Vice President of Clinical Quality for North Star Anesthesia. So I'm working with the team there. Thanks. In CRNA services, I'm working kind of as a joint effort with Josh Lumley, who is the Chief Quality Officer, and of course all the team there, those that have gone through the fellowship. So excited to come on board and continue the work we've been doing in our space and working with them. And, they have a huge team spread across the U.S. that can really impact care. I'm super excited about it.
So congratulations to everybody. And we've already said congratulations to Lee Fleischer on his new position as well. You picked up on that, I'm sure, Sol, on which is great. And we promised that I
already sent him a Mazel Tov email.
Well, Sol and Jeanna, thank you guys so much for joining us. Mike and Denny, thank you guys so much for sticking around, because I know that it's been a very long day for you all there too. Jeanna, I can't tell you how much we are so excited to have you featured at our EBPOM USA meeting coming up in Chicago. and all the work that you're doing. I congratulate you on all of that and can't wait to hear more about it. It's really, I'm sure, going to be impacting care for a long time. So great job on that.
Thank you so much. I'm excited.
Yeah,
and congratulations
absolutely.
to you.
Thank you. Thanks so much. Sol, EBPOM USA, where can we find more information?
EBPOM.org, and just follow the roadmap to September 11th, 12th, 13th.
TopMedTalk. Nick Majerison here. Thanks for downloading TopMedTalk. TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.